Hi guys, back again. Sorry, cut out a little bit. So as we were discussing for the treatment options, the final option is surgery, which is reserved for PD patients who have exhausted all other medical treatments for their tremors and their profound motor fluctuations. Currently, there are two main surgical treatments available. That includes deep brain stimulation and a DUOPA. DUOPA is a surgery that's performed to insert a tube into the small intestine, which delivers a gel formulation of carbidopa or levodopa, which increases the amount of dopamine that is in your body and helps to increase that neurotransmitter, which is essential for movement. Um, in deep brain surgery, thin wires called electrodes are placed on one or both sides of the brain in specific areas, either the subthalamic nucleus or the globus pallidus interna. Those two centers of the brain control movement primarily. So usually a person remains awake during the surgery, so he or she can answer questions and perform certain tasks to make sure that the electrodes are positioned correctly. However, some medical centers are now using brain imaging to guide the electrodes into the proper spot while a person is asleep. Each method has its pros and cons and may not be suitable for everyone, but it just depends on what that certain center has to offer. So once the electrodes are situated, they're connected to a battery-operated device similar to a pacemaker for a heart, and it's typically placed under the skin below the collarbone. Next, the neurostimulator, which is a device, delivers the continuous electrical pulses through the electrodes to decrease Parkinson's symptoms. The exact manner of how deep brain stimulation works, not completely understood, but many researchers believe that deep brain stimulation regulates abnormal electrical signaling patterns in the brain. So, in order to control normal movements and other functions, brain cells communicate with each other. And in Parkinson's disease, these signals become irregular and uncoordinated, leading to motor functions that are enabled. So now with the DBS interrupts this atypical signaling patterns in a way that allows the cells to communicate more smoothly and lessen the symptoms of that patient. So now we'll move on to a case study, and this case study is actually near and dear to me. This is actually representative of my Uncle Mark. So my Uncle Mark, he's a 60-year-old male. He was diagnosed with Parkinson's disease about 5 years ago, and the symptoms have progressively worsened each year. He's about 6 foot tall, roughly 210 pounds, has normal blood pressure, heart rate, and cardiovascular levels, um, cholesterol levels, sorry. And he has no family history of Parkinson's. Mom, dad, no aunts or uncles or grandparents have Parkinson's. He's seeking exercise and physical therapy recommendations due to recent history of falls and decreased functionality in the activity of daily living because of his Parkinson's disease. Um, he has body impairments of postural and lateral extremity muscles, balance and coordination. Walking is a problem. He's very fearful of falling. So it limits his participation in activities and moving certain places and how much he does during the day due to the complications of the PD. So he is actually currently taking levodopa to increase his dopamine levels. So the recommended exercise prescription that I prescribed for him was 2 to 3 days a week each of aerobic resistance and flexibility slash balance exercises. The most would probably be flexibility and balance because he is having a hard time with his gait. He has an abnormal gait, which means that he's struggling to walk correctly. He's constantly dragging his feet. So um, the first would be just to make sure that we're maintaining the range of motion for all the muscles. So, we want to hold a static stretch for 20 to 30 seconds to the point of slight discomfort and tightness. And we want to do balance activities such as tandem walking, alternating standing on one limb, and gait exercises, closing eyes, different various balance activities to increase his balance and decrease his risk of falling. As for resistance training, prescribe 8 to 10 repetitions per set without significant fatigue. Um, Using the RPE scale, you should be roughly 12 on a 6 to 20 scale, no higher than that. Recommended 1 to 3 sets for each muscle group, and 2 to 4 exercises per muscle prescribed. And if we had a client that had a further stage of PD, then you could switch that to have them be comfortable, and usually 2 to 3 minutes rest per set. And always use equipment that is safe and the patient is comfortable and knows how to use. So you may have to show them and obviously supervise them to make sure they're not going to hurt themselves. As for aerobic training, 2 to 3 days a week, 60 to 80% of the max heart rate, 30 to 60 minutes if you can. No more than 60, but definitely trying to keep the cardiorespiratory aspect of his health maintained. If the patient has a progressed stage of PD, then you might want to do multiple bouts of 10 to 20 minutes based on what that patient can handle. And whatever they like to do for aerobic activity is fine. Yoga, dancing, boxing. Usually, if you're just trying to do regular aerobic exercise, try to do treadmill or regular walking. But if the progressed stage of Parkinson's disease is so vast that they can't, then you have to use the rowing ergometer or a bicycle to make sure that they're safe and comfortable. If you'd like some more info about Parkinson's disease, these are 3 great websites that I found that really helped give me the most information and the most valuable sources that can help you inform you about Parkinson's disease. Um, and these are citations that I used for this presentation. I hope you enjoyed my presentation, and I hope you learned a lot about Parkinson's disease. Thank you very much.